nice cases which all of you would be seeing in your daily practice. This is a 32-year-old male patient who comes with a history of redness and watering from the left eye since the last 3 or 4 days. He had a history of trabeculectomy done in both the eyes 10 years ago for juvenile open-angle glaucoma, uncontrolled with maximal medical therapy when the surgery was done. There's no history of injury or exposure to any irritants. There's no history of any other systemic disease. No history of being on any medical therapy, either systemic or topical, to give rise to that redness in the eye. On examination, both his eyes showed a best corrected visual acuity of 6.6 and N6. His right eye showed a cystic encapsulated bleb at 12 o'clock with a quiet eye. And his left eye shows a conjunctival congestion with a thin avascular cystic bleb at 12 o'clock. The pressures in both the eyes were 10 millimeters of mercury. The corneas were clear. The left eye showed a very well-formed anterior chamber. There were no cells, flare or hypopion. The pupil was reacting well to light and the lens was clear. This was what the right eye bleb looked like. This was what the left eye bleb looked like. What, in the panelists' opinion, would be their impression? Would they just look at the left eye as conjunctivitis? Would they think of it as blebitis?
Yeah, well,
you see here, this is the thinning of the bleb there.
So this is definitely at this stage what I would think is that this patient has conjunctivitis, but he has a high risk for going into blebitis and bleb-related endophthalmitis. So you would treat with antibiotics, and most important is tell the patient to take care that he doesn't rub his eye too much, doesn't touch his eye with unsterile stuff, or use only sterile swabs to clean his eye. And come for follow-ups frequently till the thing settles down well enough, and give us an opportunity to act if something does turn up. How to identify a patient who is going in for blebitis as compared to this picture? If I see much more congestion at the bleb area with a whitish kind of thing inside the bleb, then I would identify that. Or a stain positive with a leak. In this, there is no leak, but if this patient was leaking, then it is an even higher risk. Even if he is having a kind of weeping bleb, where the bleb is not, there is no
sweating
bleb kind of thing, then also that is a higher risk for developing intraocular infection and blebitis.
Any other panelists have anything else to say? I think we would all agree that this is basically just a conjunctivitis. However, because there is a thin wall cyst, we would definitely be very, very careful. This was when I had stained this patient only to do his pressures.
Yeah, so the yellow thing is fluorescein.
That's the fluorescein that was left behind after the pressures. If you had identified blebitis, what next? Would you have wanted to do a culture sensitivity? Would you start off with a presumptive antibiotic? What would have been the chances of a hypopion? And should we do anything else?
The fact that there is no hypopion and no intraocular inflammation would make it blebitis. Otherwise, I would treat it as endo. There is no question.
Okay. Now, if you found that it was blebitis, would you want to go ahead and do a culture sensitivity before you start off with an antibiotic presumptively?
Yeah, I would do a culture sensitivity so that at least I know. But unfortunately, when by the time they reach a quote-unquote glaucoma specialist, like all of us are, they're already on presumptive antibiotics. So I'm not sure how much the culture sensitivity would work, but I would do it nevertheless. But my choice would be topical cefazolin for him and one of the amikacin or something. Because I would want to cover gram-negative as well, not just broad spectrum.
Yeah, so the lesson, the take-home message just now would be that yes, instead of just using a presumptive antibiotic without thinking, it would be much better to take a conjunctival swab, do a culture sensitivity, and then start off with an antibiotic. It's only a matter of days when you'll know whether the antibiotic is acting or not, and then if it is not, you know which antibiotic to get back to.
Rita, I'm not sure we would wait a couple of days.
No, you would start with an antibiotic, but if it doesn't respond, then you can always fall back to see what has happened. Now actually, immediately after having done that, I sort of thought that the cyst was the bleb was extremely thin at the center. So I did what Manish told us to do, not just instill fluorescein like we do for for checking the intraocular pressure, but rub the fluorescein strip on the bleb as hard as you can, paint it all over, and this is what I saw. So this was definitely a Seedles positive. And when you see a Seedles positive, then you become far more aggressive about your treatment. So what we did was we continued to treat him very aggressively. At this point in time, of course, everything changed. We continued with the medications, but we were very, very aggressive, and we were watching him almost on an alternate day basis. We could not have just left him to stay home, use antibiotics, come and see us after a week. No, we saw him alternate day. Do you think that we should jump to surgery at this point of time? When would you contemplate surgery? What are the surgical options available? What is the rate of success in terms of preventing an end-off and in terms of saving the filter and maintaining the intraocular pressure?
I will never jump to the surgery. I will wait for the patient's response to the antibiotic. You can involve your colleagues also in decision making, because sometimes this becomes a medical legal issue. So it is better to have two opinions, and then surgical option can be taken off if the patient is not at all responding and you see hypopia inside. Otherwise, I will wait for 2 days for that culture report to come.
So
but we have one point I would like to make.
Yep.
Whenever you do the surgery of glaucoma, particularly we are using a lot of mitomycin or anti-metabolite, it is must that we inform good counseling to the patient that these you for lifetime you have a chance to develop infection or phlebitis, which is sight threatening. So that kind of warning or counseling should be done to all the patients. This prevents the aggressive nature of the phlebitis. As soon as they notice the watering or red eye, they should come and see us. That information should be given to as a prophylactic.
I agree with Mayuri completely. However, this was 10 years down the line. This patient was operated 10 years ago, and we have very short memories. However hard you might have told the patient at the time of surgery that, listen, if you get a red eye, please come to us, please come to us. 10 years down the line, that doesn't make any sense to them. Though, of course, I agree that we have to counsel them. And every time they visit us, you must sort of look at them and spend a little time with them, and probably counseling helps in a very, very important way. Sunil, do you have anything to add?
I think in counseling, 2 factors which I tell the patient is at least don't go back to the GP. Okay, go to an eye doctor because they will know what's happening. And they tend to go to the chemist and use a steroid
drop. I think that's very important, that they shouldn't do self-medication.
Self-medication. And second thing is basically avoid splashing water into the eye. We have a very normal habit in our country, splashing water into the eye, and especially in patients with glaucoma surgery. This is one important tip I tell them, that you have to avoid splashing. Again, a couple of patients are swimmers, and swimming without glasses is very important, because I had a patient who was from Dubai and she had her own swimming pool, and she used to get this recurrent phlebitis. But nobody told her that wear your glasses on. And the day she started that, her episodes of phlebitis reduced as such. This is the counseling part.
Yeah, I think that's very important. I think counseling plays a very, very important role in the practice of glaucoma. The more chair time you spend with the patient, the happier your patient is. I think we spend a lot more chair time than any other consultant in any other branch of ophthalmology. Now, what would you do with the other eye? Would you want to, just counsel and wait? Would you want to take up something? And at the end of the whole process, we treated him. I'll show you what happened. We did this. This is a picture that we did only last week. I have treated him. We've done a CDES. The CDES has turned out negative. Then I did a forced CDES. When you do a forced CDES, you paint the gleb as much as you can. You see there's no leak. Then you apply a little pressure at the lower lid so that there is an egress of more fluid, and then you see whether there is a sweating or if there is a leak happening. Now there is no leak happening, but apparently there was a little sweating happening. Therefore the entire stain sort of went on to the periphery, which then tells me that all is not yet well. I probably need to continue to treat him. Now, having done this, would this be the end of the story, or would any of the panelists suggest that at this point in time maybe I should contemplate surgery, go back and do something to make that thin cyst thicker?
I think medical line of treatment, probably we have missed a point of using tobramycin or gentamicin, which is a very good thing. It actually irritates the conjunctiva and causes kind of visualization. In addition, you have to use aqueous suppressant so that your aqueous going across the bleb area, leakage, gets less. and the healing occurs much more better. So these kind of bleb leaks, usually the milder ones and the slower ones, heal very well just using topical gentamicin and aqueous suppressant along with it.
Correct. We have to think of you going back to gentamicin, because gentamicin does, set in some amount of irritation, and it acts on the conjunctival epithelium to give us a much thicker kind of a bleb. If that doesn't happen, and if we are still left with a leaking bleb, despite whatever medical treatment we have done, that's when we probably think of going to surgery. And what surgical option, Manish, would you think of at that point in time?
I would prefer to go and just excise the diseased conjunctiva or unhealthy conjunctiva, undermine the behind and bring it a little bit forward and suture it there, so that you have covered the thing again with fresh, healthy conjunctiva.
Sometimes that happens, and at other times what happens is when you open that unhealthy conjunctiva, you notice that the leak is not only happening only from that cystic bleb, but there's some leak happening, there's some leak happening even from the scleral flap. And that is when you have to do a more extensive surgery, where you have to close the leak that is happening, either by using whatever. You can dissect the sclera adjacent to it, and partial sclera can be again stitched back over the leak. You can use an artificial sclera, you can use an artificial cornea, you can use whatever you get, but you have to seal. You can use an amniotic membrane, do whatever, but seal that leak so that you know that there's going to be no leak happening henceforth. And what would you do to the other eye? Okay, and another important question I forgot to ask you is, after having done all of these surgical processes, what is the in terms of preventing and the filter, or in terms of maintaining the intraocular pressure, what has been your experience? How often have you been able to do a good surgical repair in such cases and been able to maintain the filter as well as it was before you did a second surgical intervention?
I think it's 50-50%. Some of them really do well, but some of them really scar down and you have to do a resurgery.
Yeah, so that's another thing that you have to remember, that yes, you might do everything, but at the end of it all, you also want a filtering bleb. So, any questions on that? Does anybody in the audience have anything to offer? No? Okay, let me go on to the next case. This is a 68-year-old female patient who comes with a history of watering, foreign body sensation and dysesthesia in her left eye since long. She's been operated for a trabeculectomy in the left eye 1 year ago. There's no history of redness in the eye, but she's very uncomfortable due to the foreign body sensation. She is on anti-glaucoma medications in the other eye. She's also a diabetic on treatment, but in control. On examination, the right eye shows some conjunctival hyperemia. That's because of the medication that she's using. Everything else is normal. The left eye shows an overfiltering, overhanging bleb with pressures of 8 millimeters of mercury, and there is a Delin that is seen. We all know that the spot diagnosis is of course an overhanging bleb, which is giving rise to the dysesthesia. What would you do in such a situation? What causes the Delin? Do medications work? Do you advise any surgery? And what are the surgical options available? Any one of the panelists is open to take this up. Sushmita?
Well, I would also see whether these 8 millimeters pressures, number one, is causing damage to the eye per se. So very important to look for hypotenuse disc or maculopathy, because that's an indication for surgery or doing something right away. Whether or not there is dysesthesia or Delin or anything. If hypotony is causing ILM folds or hypotenuse disc changes like hyperemia and tortuosity of vessels, if you're seeing that, and it's excellent if you had baseline disc pictures and you can compare it, because many times it gets very difficult to know whether the change is because of that. That's one. But many times, surprisingly, our eyes tolerate 7-8 pressures very well, and there's nothing that is wrong. Your heart is telling you that the pressure is 6 and I must do something, but the eye is telling you I'm perfectly fine to don't touch it. So I don't touch it. That's one. But having said that, an overhanging bleb with dysesthesia is going to be a nidus for the patient rubbing her eye, and I'd be very, very uncomfortable with this huge thin bleb. Now, Dr. Harsh has described, and I think reported in a couple of patients, I'm not sure whether he's published that, but he says that he can do a laser delimitation of such blebs, and they do very well. I have tried it, frankly, in 10, 15 of them, and nothing happens. I mean, I've tried it with gentian violet, I've tried it. So I'd like to know the experience of the other panelists, because on the face of it, it seems such an easy thing to do. You just put gentian violet or anything that takes up a dye which absorbs 532 wavelength, argon green or 532 nanometers wavelength, and apparently it just contracts. And if it does, it scars the periphery, so non-invasively you decrease the bleb height and everything seems to be okay. Now he shows them, and I keep asking them, I don't know how you do it, but it hasn't worked with me. So I wonder if any of my other colleagues have. What I do personally, if I have to intervene, I just excise the extra excess bleb, take all this unhealthy tissue out and bring in healthy conjunctiva. That's what I do.
Manish, do you have anything to say?
Well, the thing what you described or what Harsh describes about the gentian violet and all, well, I haven't tried it, but I think it won't work in this kind of situation. He's just talking about very large blebs, not with thinning. When there is thinning, because even if you reduce the size, that thin area is still not healthy. It is still going to lead to leg leaks and maybe endophthalmitis. So this will have to be recovered. Yeah. This delimiting the size. But with the Delin and all, I think the surgical option would be a total revision.
Mayuri?
All symptomatic blebs I will always tackle surgically. I will not wait. Because it is a potential threat for the future.
Okay, now I have a few options to offer you. I thought that if you just have a simple overhanging bleb, maybe you can just put in a compression sutures, and you put those compression sutures, they're very easy to take. You just take a simple 10-0 nylon and you go through the partial thickness of your conjunctiva and you come out the other side, and it sort of literally compresses the bleb, brings it back, and take tight sutures. And
does this cheese wire? I mean, that's what.
No, it doesn't. It doesn't. You just you got to be when you're taking that suture. Then you shouldn't take it so tight that it is cheese wire, but you have to take it tight enough so that you are able to.
No, not immediately, but I've noticed 3 to 4 weeks later.
No, but you take them off in a couple of weeks. You don't wait for 3 to 4 weeks. In a couple of weeks, you take it off, and everything is back in place, and it looks pretty normal. So this, I think, also works pretty good in patients who have small overhanging blebs. If you just had an over-filtering bleb, would you think of doing an active intervention, which already Sushmita has told us that unless there are, really, really demanding features like maculopathy, you won't want to really go and do something. Now, of course, like what they were discussing, what Harsh has said, there are many other things that people have done to try and induce fibrosis in these cysts. For instance, you can use a small cautery. You have these electric wire cauteries. I've seen them being used quite a lot in Basking Pharma. They just use those little cauteries and they give few cautery marks on the surface of the bleb, and the bleb shrinks and the size decreases, and so you get your bleb to decrease in size and cause less dysthesia. Then, of course, there is application of trichloroacetic acid, which people have talked about. And then there is, of course, injection of autologous blood. Has anyone tried?
What cautery is this? The normal?
It's the normal cautery.
The normal bipolar?
Yeah. No, not the bipolar. It is that little wire electric cautery. It just induces a little heat and it induces fibrosis. And it's just very tiny. I don't even know the size of the wire that is used. For all surface wounds in general surgery. Now, the other thing that people have talked of is using autologous blood injection. Has any of the panelists had any experience using autologous blood?
Yes, I have used autologous blood, and I have finally got. It's quite exasperating to keep giving injections and nothing happening, so I have stopped using it now.
Yeah, in fact, all of us probably have done this. Literally out of desperation, we want to do something. So the easiest thing to do is inject autologous blood and wait and see something. Wait and hope that something will happen, and nothing happens. But there have been reports that autologous blood probably helps. Now, what if you have blebs like this? There have been examples when we've had overfiltering blebs like this. Okay, I mean these are blebs that I have seen. These are blebs of patients whom I have actually seen. These are my own pictures. So what do you do when you get blebs like this?
Actually, the one at the upper one, it's usually a pedunculated bleb.
Yeah.
So there are 2 parts to it.
Yeah.
And if you kind of tie a knot between the peduncle and kind of just tighten it, it just snips off. and there's no leakage. So that's the best part. Actually, then the patient gets immediate relief symptomatically and cosmetically as such.
And it's amazing how they've lived with these blebs. I've had this patient who came to me after having had a trab some 15 years ago, and he says, "ये तो कितने सालों से है, अभी तो पता नहीं पर है, अब देखो कुछ कर सके तो." So we have patients who have so much tolerance, thanks to the tolerance level in the patients. So yes, of course, if you have blebs like this, you have no option but to go out and excise them. We go on to the third case. This is a 48-year-old male patient operated for trabeculectomies in both eyes 3 years ago. Comes with a history of swelling in the left eye since the time of surgery. The swelling is at 12 o'clock and has not diminished in size after the surgery. He is hypertensive and diabetic on treatment. His intraocular pressures are well controlled, 14 and 15 millimeters of mercury respectively, and his vision is also good in both eyes. Fundus shows advanced glaucomatous optic neuropathy in both the eyes. The bleb in the right eye is well formed. There are multiple microcysts and it's a diffuse bleb. The bleb in the left eye, however, shows a circular swelling at 12 o'clock. It's a thick bleb that is quite circumscribed. I'll show you the pictures. This is the right eye. It's quite a nice bleb, and that's the left eye. And you can see how circumscribed and these are all blebs. What would your diagnosis be? I've shown it, I know, but before that, would you think that this could have been an encysting bleb?
When was the surgery done?
3-4 years ago.
Yes, when Ologen was there.
When Ologen was there. Obviously, for me, since I had done the surgery, I knew it was an Ologen implant, but I thought this was an interesting case to put up because what if you see, a picture like that, and it could look like an encysted bleb, and then how would you be able to differentiate it? Supposing this patient hadn't come to me, it gone to somebody else, or if you happen to see somebody's patient, what would you do? Would you think it's a Keenan cyst? Would you think it's an overfiltering bleb? It could also have been a retained MMC sponge. But once in a way, we've seen that happen too.
I think. Have you done imaging in this patient? Lab imaging.
That's going to come to that.
Yes, lab imaging.
They would treat her even if we had pictures like this and the pressure was 12 and the trap was done
2 years ago.
I wouldn't do anything. I would be very happy.
Yeah, I didn't do anything. I'm still happy with it, but this is just to show you that. Yes, is there any diagnostic modality to find out the details? Yes, we could have done an ASOCT and found out what it has, and yes, it was an Ologen implant, but I can show you. And there's a UBM picture, and this is the detailed picture of the bleb. Now, would you leave it? It does. That's what I'm saying now. How long does an Ologen implant take to disintegrate it? Ideally supposed to disintegrate in 90 days.
6 months maximum.
In 90 days. If not 180 days. If not 1 year. If not 2 years. Now it's been 3 years and this patient still has the Ologen sitting as it is, but it's fine. The bleb is functioning very well. Now, would we want to do a surgical excision of this?
No.
The patient is not complaining of any dysesthesia or anything, but he's just saying, oh, you put Ologen in both the eyes and then this eye has got like this swelling and the other eye is like looking quite nice. Aise kaise ho gaya? So, yes, we have to allay the anxiety of this patient by just doing good counseling, and you've got to just for placebo effect, I'm giving this patient lubricants. Would any of the panelists want to do anything else?
No, lubricants.
Would you give lubricants or would you say kuch nahi hoga? Everyone gives lubricants. We keep giving lubricants thinking that they will sort of take care of the whole affair. Now tell me if it's 4 o'clock, I have no access to a watch because we have to leave the hall at 4. It is?
It is.
So we shall wind up. Thank you very much everybody for attending this IC and making it a success. I want to thank my panelists, my co-instructors. They've done an excellent job. Thank you very much.
The nucleus is divided into small pieces and we can manage it accordingly. Like my mentors and everybody at one time when I was learning phacoemulsification did tell me, they were standing next to me, and once I got the crack, they used to say, case over. So that's the importance of getting a good nucleus practice. So in this IC we'll be talking about different things, how we can go ahead and do that. I welcome my co-instructors here. There's Dr. Nausha Shroff. Most of them in fact, any one of them don't need any introduction. Dr. Nausha Shroff is a recipient of the Padma Bhushan Award. He's a trustee at the Shroff Charity Eye Center and the medical director at the Shroff Eye Center. Dr. Rishi Mohan, alumni of RP Center AIMS. He's been an ophthalmic surgeon in Windsor, UK, and he's been attached to the Orbis Flying Hospital. He's the medical director at Lasertech, the MMI Tech, and the Seva Eye Bank. There's Dr. Ashu Agarwal here. He's a cornea fellow from LV Prasad. He has actually started the cornea services at Benu Eye Center and the Eye Bank there. He was for a long time associated there, and he's a director at the Perfect Sight Centers right now, and he spearheads the Perfect Vision group in their ophthalmological practices. There's Dr. Sanjay Chaudhary. He's done a training at Gimbal Eye Center. He's the director of I7 group of hospitals, which have so many centers now in Delhi. He is a pioneer in ICLs and the IOL implants, and he was one of the first few to have started the phaco's, the femtosecond cataracts. So he's another pioneer there, and that's me. I'm a part of Eye Care Eye Hospital and Postgraduate Institute in Noida, and so, as I said, we're talking about the nucleus fractus. So first, what does nucleus fractus mean? It means that we are dividing the nucleus into smaller pieces. So as I said, if we are able to divide it into small pieces successfully, we are through with our case. Now, like any other thing, it is very essential for us to be able to assess the cataract. And unlike a ECC or SICS, where any type of cataracts we can go ahead and do the same procedure, here we have to think and manage the case accordingly. And even if we're doing the same technique in all our cases, we also need to change our parameters from time to time, and we have to be very careful with all these. So a thorough evaluation is necessary before deciding the approach how to manage the cataracts. Now, I thought that this is an important slide, and this is the lens opacity classification system 3, which is very, very important for us to be knowing about. We should be able to classify the cataract according to the opacities present, the opalescence present, and we should be able to see the cortical and posterior capsular cataract. These comes on a transparency, and we can actually see it with the slit lamp photographs, but it is slightly cumbersome, but we should be aware about that. Now, techniques of managing the nucleus have been manifold, but there has been a pre-capsular excess era. That means that before the capsular excess, when Kelman started in the 1970s, anterior chamber phacoemulsification was being done, a Coruscant method, and it used to do that. It had its own complications. There were a lot of pros and other cons, and the cornea was something which was getting damaged. In the 1980s, the capsular excess and the hydrodissection came in, and the endocapsular phacoemulsification came into being. Now there are three main techniques. Techniques with the nuclear fractus, a mixed sort of technique, and the techniques with pure nuclear fracture. So when we say without nuclear fractures, we mean the chip and strip, so you're just creating a crater and just taking it out, so you're using phaco energy to do that, or maybe if it's a soft cataract, you're not even doing that, and the Shepherd's technique. The mixed technique is the divide and conquer, which Dr. Nausha will be talking about, creating a central trench, rotating it around, again another trench, dividing it into four, and just emulsifying the small pieces. And pure nucleus fractus techniques like the phaco chop and the stop and chop. Now, as I said, the aim of the objective of the course is to demonstrate the various techniques of nucleus management and choice for the right technique depending on the type of cataract. And I will request Dr. Nausha Shroff to come over. He will talk about the classic divide and conquer. After that, Dr. Rishi Mohan will talk about the stop and chop, and Dr. Ashu Agarwal about the direct chop. We'll take a break there because we'll be covering most of the things here, and we can have a panel discussion as Dr. Rishi Mohan and Dr. Ashu Agarwal has to move on to another IC which they are a part of, which is at the same time going on. After that, I will talk about soft nuclei, how to manage them, and Dr. Sanjay Chaudhary will give a potpourri of how to manage sticky situations. So, Dr. Shroff, please.
Inviting me to this instruction course. I started phacoemulsification in 1988 when very few people were doing phacoemulsification, and therefore we had many problems, we had complications. Today you are in a situation where you cannot afford to have those problems. because you are in a very, very competitive situation where others are doing phaco flawlessly, and therefore you should not get into problems. Today, everybody, most of the people here are preaching the direct chop techniques and other techniques, but for the beginner, I still feel that the divide and conquer technique is a very good technique, and I'll go through some animations, some slides, and some videos which I'll share with you. The ideal nucleotomy technique should be safe, that is least traumatic to the endothelium, and with minimum chances of PC rent. It should be easy to perform and easily reproducible. Now, what are the nucleotomy techniques that we have? We have the divide and conquer technique, the stop and chop technique, and the direct chop technique. And today I'll be talking about the divide and conquer technique, and my technique is a combination of the 4-quadrant cracking technique with some features of the stop and chop technique, and therefore I call it the quadrantic cracking, chopping and stuffing technique. Firstly, the central debulking and pre-grooving of the nucleus. You can see this is an animation showing that the bulk of the energy is dissipated within the body of the nucleus, and you are far from endothelium and posterior capsule. So, people saying that quadrant technique, quadrant technique is more damaging to the endothelium is not correct, because majority of the energy is dissipated inside the bulk of the nucleus, and hardly any energy is dissipated and is dissipated towards the endothelium. The first step is the sculpting, sculpting, which debulks the central core of the nucleus and creates a trench. This is extremely important. Ensure that there is no central island. When you debulk, what happens is the central portion of the core of the nucleus, there is a hump there. And when you start cracking or chopping, you chop in the periphery, but you don't chop or crack in the center. And this is extremely important, because this island should be debulked. And there I found the Kelman tip very useful. It's an angled tip, and as you see in this animation, you have a very even posterior plate and no bump on the posterior plate. The next step is ensure that the depth of the groove is enough to facilitate cracking. Now, the depth of the groove, there's a teaching that it should be the diameter of 2 phaco tips. But what I usually take is that it should be deep enough so that you see the red reflex and are able to crack easily. I think there's something wrong. Okay, hey, that's all right. When you are trying to crack, a minimum of horizontal force should be required, and you can do it with either with 2 instruments, like the phaco tip and a second instrument, or you can do it with can be done with 2 instruments. Your caution should be taken that the 2 instruments, the 2 hooks should be deep inside and not superficial, so that you can do a successful cracking. So the advantage of cracking are there's minimal stress on the zoleus. Also, we must remember that for a beginner it is easier to handle 4 small quadrants than 2 large ones, and therefore it is much easier for the beginner. And here, can I have the? You want this one? Yeah, I think there's something going wrong here. I think 2 different systems in it. I'm sorry, but sorry about this because I think we changed red reflex. And this is the video in which there's the sculpting is being done. As I said, you should sculpt from the center, the periphery, or also in the central part of the nucleus. Ensure that you don't have a central island, as I showed you, because that will prevent you from cracking up to the center of the nucleus. And that's extremely essential. The cracking to the center is essential, because what we do is we crack in the periphery, but the central portion is still left. As you can see now, that almost the 4 grooves are complete, and this is the 4 quadrant. This is the last grooving of, and you see a Maltese cross at the end of the sculpting. The next step is the cracking. When you do this, as I told you, you can do it with the phaco tip and the second instrument, and there will be minimal horizontal forces are required for cracking the nucleus. And you can crack with the 2 hooks, as I showed you also. So, and I mentioned that the cracking, the advantage is the minimal stress on the audience, and it's easier to handle 4 quadrants than to handle 2 halves. And now is the cracking. You can see we can go deep into the sculpted portion. Here now what I am doing is that I am not cracking, but the second quadrant is being almost chopped, because sometimes it is not so easy to crack it, and therefore it's easier to, although it's a 4 quadrant technique, we are making 4 quadrants, but we are chopping each quadrant into each half into a quadrant. As you can see, because it's easier to, we go into high vacuum and hold the quadrant and chop, and now you've got these 4 quadrants. So as I said, it's easier to handle these 4 quadrants than to handle 2 halves. And now the chopping and stuffing technique. What I do is that the quadrants are then chopped, as you can see, chopped into smaller and stuffed into the phaco tip. What is the advantage? Chopping and stuffing reduces the phaco power and time, and you get clear corneas first post-operative day. And this is the 4 quadrants I've already made. Now each quadrant is taken up and chopped further into 2 and emulsified. Here you require a little less vacuum, because it's in the holding that you require. When the chopping you require more vacuum, but in the emulsification you require less vacuum. And now the fragments are being taken into nasally, because we are operating temporarily, and then again the phaco tip is introduced, and as the bag becomes more bare, you should reduce the parameters, especially reduce the vacuum and flow rate, so that you don't get the posterior capsule into your tip. And as you can see now, you are feeding the phaco. Now as you can see in this, now it's being chopped again, this quadrant, and it's stuffed into the phaco tip with the second instrument, and therefore when you do this stuffing, the phaco power gets reduced considerably. This is one sticky situation when we come across when we are doing a quadrant technique. We have done all the quadrants, but still we cannot reach these quadrants, and this is true in a brittle sort of a cataract. And you have unsuccessful attempts to impale and hold. As you saw in this animation, you try to hold and you impale, and then you eat up a little part of the nucleus, and therefore there is a risk of damaging the capsule rexus or the posterior capsule. So what we do is we have a safer alternative. We inject OVD under the fragment over the posterior capsule, tip up the fragment safely, and then apply the phaco tip to the posterior part of the fragment, and therefore you are far away from the posterior capsule. And this is a situation we come across quite a few times when it is known that you are neither here nor there, in the sense that neither is it a very hard cataract nor is it a very soft cataract. It's a brittle cataract which you can't reach to. So my technique, it combines the safety of quadratic cracking with the efficiency of stop and chop. It is good for most cataracts. In fact, it is even very good for hard and brown cataracts. It is safe and reproducible, and this technique is good for the beginner and the experienced. So I feel on the whole this is an excellent technique, and especially the beginner shouldn't feel, after seeing all those grand videos, shouldn't feel that he is anyway less competent, and you will deliver extremely good results with this technique. Thank you so much.
So before we go on to the next speaker, one question to you, Dr. Nasir. You talked about the small fragment and you were putting a viscoelastic under the fragment and picking it up. Many times you get into a tricky situation. That means you have a thin plate, and a lot of phaco surgeons try to use the phaco tip, and they position the tip in such a way that they try to engage the posterior plate and pick it up.
That's, I think, there are only two alternatives. When they have these situations, either you go into the bag and prolapse it, because they are not hard nuclei, they are brittle nuclei. Either you try to prolapse it and bring it into the pupillary plane, or this is the other technique in which you inject viscoelastic, you really inflate the bag, you are far from the bag, and you take a blunt instrument like the Leicester hook that you saw, and don't point it downwards, point it sideways, tip the fragment up, and then impale it. I found that very extremely good.
No, but what do you do in that situation where you have a thin plate left, a hard brittle plate, and after you've done all your trenching?
So normally when the quadrant is you hardly have this. That thin plate can easily be prolapsed out by injecting a viscoelastic and floating it up. Any other questions?
I think we'll take the questions after we have all the three speakers, and we'll take a break and we'll take the questions then. Thank you, Dr. Nasir, and I'll ask Dr. Rishi Mohan to go ahead with his talk on stop and chop. Thank you.
Thank you very much, Saurabh. Good afternoon, ladies and gentlemen. I think I'd like to thank Saurabh for inviting me to be a part of the faculty on this course. It's a pleasure to be here. And I'm going to take it to the next level, which really suggests that that I'm going to talk about a technique which is a little different from the original divide and conquer. And has been very elegantly shown by Dr. Nasir Shroff with those animations. It does tend to give a response in most situations, but there are certain areas where the divide and conquer is probably deficient in some ways. It is an easy technique and it can be used even with a single hand, but the problem is it uses slightly higher energy, it takes a little longer time, uses a little more fluid. The phaco chop, which is again the direct phaco chop for the harder cataracts, is going to be discussed as well, and that uses much less energy. Essentially, any technique in which we're going to use manual energy in chopping is going to use less energy on the machine. So it's a direct corollary. You're trying to break up a piece of stone, and you can either use machine-based energy or you can use your hand. And the more hand you will use, the less energy you'll use. It's pretty straightforward. The problem with the chopping techniques is that you need a better two-hand coordination. You can damage the anterior capsular rims, and you can get pieces stuck in what we call the jigsaw puzzle, wherein the pieces tend to mash into each other and don't get mobilized easily. So Dr. Paul Koch invented the technique of what he called stop and chop, which is something in the middle of divide and conquer and phaco chop, in which he split the nucleus into two halves, and then one stops doing more divide and conquer and then starts to chop each one of these pieces independently. So it requires less energy and pieces can be mobilized much better, and it reduces the chance of the chopper damaging the capsule as well. So here's a patient who has a posterior subcapsular cataract. Now, as you can see, I'm not doing any hydrodissection here. I'm worried about the posterior capsule. It's a grade 2 nucleus. And what I always do is to try and create a little bit of a crater in the middle, because I like to delineate my rexus as well as create this crater to take the epinucleus and the cortex out of the way. And then I go into that initial groove or trenching, and as the stop and chop phacoemulsification conventionally has, you make one large groove in the center. I do tend to create a little bit of a side groove as well, because it helps the management of the nuclear pieces, because they become a little smaller in the center. You keep going down, and then with your other hand you just crack it into two pieces, and then remember there is no hydrodissection here, so it's not always easy to mobilize this nucleus within that cortical bag rather than capsular bag. but with a little bit of work, without putting too much of stress on the zonules, you can mobilize it, because if you have a good hydrodelineation, you can do that. Thereafter, it's breaking up each one into two pieces. Here we are doing a 4-quadrant breakup, and then each individual piece is then brought into the center of that crater-like area, where you can do either an in the bag or at best an iris plane phacoemulsification. We go on with this in the same fashion. We pretty much do a little bit of a chop. It's actually a mishmash between a real chopping maneuver and a slightly cracking maneuver. It's not a pure chopping maneuver, and you don't need to have a pure chopping maneuver, because once you've impaled the phaco tip into the piece, you can actually go in underneath the capsular rim and take these out. So that is one, and this is another video showing here the hydro procedures are being shown. The first one is the hydro dissection, where we are cleaving the capsule and the cortex, and the next is we're going deeper in and doing the hydrodelineation, and you could see the two independent fluid waves moving backwards. And this is relatively easier to mobilize. It's a harder nucleus than the first one. This is a grade 2.5, and once you have the mobilization, we again go in and I create that little crater. This also tells me where my rhexis edge is, because I don't use trypan blue in my patients routinely. And I go in with the probe, and I create my central trench and go down till, as Dr. Nausher very rightly said, the best depth is to see when the color changes in your red reflex at the bottom. And that's what tells you that you're at adequate depth for cracking. It's sometimes difficult to determine two tip depths, because tips are different. We use a 0.9 tip, people use a 1.2 tip. So 1.2 tip would mean a 2.4 depth. Here then again we put in our non-dominant hand, in this case it's a left hand, and we complete the crack, and you can see the brightness that comes up at the tip there, and that tells you that there's fairly adequate depth for you to crack. Classically, when Dr. Koch described his technique, he wanted the nucleus to get rotated 180 degrees and then crack the other end, whereas I just do it in one go. There's no need to rotate it 180 degrees to do the other end. You can just do it in one go. And here again I'm using, since it's not very hard cataract, I can get away with just a 4-quadrant breakup. The annoying air bubble always pops up just at the point where you want to do all your work. And so one just aspirates that. And simultaneously, again the same thing is repeated for the other half, and completed in that fashion. Each piece is then aspirated or pulled out from underneath the bag, and one has to be careful here that one doesn't snag the epinucleus, because if you bring out the epinucleus, and you see what I do with my non-dominant hand, I ensure that I keep the epinucleus away, because I would like the epinucleus to continue to give me the protection for my posterior capsule, and this is how it just continues to work. So the whole thing is aspirated, and here I remove my left hand to ensure that I have adequate depth. I can always replace this with a blunter instrument like a wire rotator or a Lester, and in case the epinucleus doesn't come into my port like I would like it, I take down the parameters drastically when I'm doing epinucleus aspiration. So there's very little phaco energy in there. It's mostly just all set on cortical aspiration settings. My third and last video here is a hypermature cataract, and so I've used trypan blue here. I've created a larger than normal rhexis. I suspect this cataract to be a little harder than 2.5, it's probably around a 3. And here, after doing the hydrodissection, again I aspirate that central portion, gives me better visibility, as well as takes away whatever little epinucleus is in front of the nucleus. And then I again create my grooves. I'm still not using coaxial illumination. I don't need it at this point. I just have 3 additional reflexes to deal with. So I put it on only when I am in a position that I really need the red reflex. I keep going down into the crater as much as possible, and then I crack the nucleus into 2, and now you can see the lights have increased, so that you can see at the time of the cracking that you've gone full thickness. These are not always easy because if the cortex is not completely milky, they don't rotate easily. That the swollen cortex actually impedes the rotation. And here we again, it's a crumbly kind of nucleus, so one can't be, you have to take the parameters down. A little bit of adjustments has to be done on the flow rates and the vacuums, and so that one can individualize the phacoemulsification to the case. Here you can see that it didn't actually crack in an exact half. It was like a 2/5, 3/5. So one doesn't have to be in a 4-quadrant mode. One can make it into 5 pieces or 6 for that matter. So whatever is necessary, and always my personal preference is to go for the piece where there is another piece lying in front of it. What that does is, if there is a surge, you'll have the protection of the other piece coming forward rather than to have the capsule coming into your port. This is the stage which is the most tricky. You must usually bring down your parameters at this stage, keep the bottle height up, but reduce the vacuum as well as the aspiration rates, so that you can get you don't get too much of surge and have the posterior capsule coming in. The last piece invariably is the trickiest piece. So that was the removal of the last piece. And this is just a study that I recently saw as recently as 4 months ago, published in the JCRS from Park's group, where they compared the 3 techniques, and they used grade 2 to 4 cataracts, which they randomly divided into 3 groups. And they looked at the US time, the mean CD, the cumulative dissipative energy, the use of BSS, and the cell counts, etc. And they found significantly less ultrasound time and energies and BSS used with the chopping techniques than with divide and conquer and stop and chop. The endothelial cell loss was also significantly lower in the phaco chop group. So obviously in experienced hands, chopping cuts down the time and the energy that one delivers in the eye. Thank you so much for your attention. Thank you, Dr. Rishi. They were 20 years ago. And I think that's what's made the big difference, just the holding power, which allows you to chop. It was the lack of holding power that didn't give us the opportunity to do chopping going back 15 years, which is why it was divide and conquer, peristaltic pumps and so on. Now it's difficult. But then there again, one has to debulk the central part of the nucleus, without which you don't have the space to work and have the security of
There, I'd just like to add that even today, when you have a really brown black nucleus and you want to debulk it, the 4-quadrant technique comes in very handy, because you've got 4 quadrants sitting on the capsule. In fact, there's no cortex at all, and it's much safer to debulk the center. And this helps you to debulk the central area or core of the nucleus, which is very essential in very brown cataracts. So it's still got a place in normal cataracts. As you said, divide and the stop and chop technique is ideal, but still, even for the beginner or the experienced surgeon who has a very brown cataract, I still feel that 4 quadrants has still got some value.
And as for beginners, I do think that stop and chop is a technique because it combines both the divide and conquer as well as chopping techniques. So if you learn on stop and chop, you can actually go on to chopping techniques or do a divide and conquer as in when the rise.
Absolutely. I think the simplicity of the procedure and the fact that it's actually able to cover almost the entire gamut of your cataracts, except maybe the softest cataracts which are not choppable.
Stop and chop. Yeah, stop and chop can cover everything.
That's what I'm saying.
Except Morgagni.
Except Morgagni.
Except Morgagni.
Parameters for which step?
Chop.
Well, my vacuums are in the range of 350 to 400, and my aspiration rate is around 30. I use the Infinity Icon system, so these are on the Ozil, and I use intelligent phaco, which means it essentially only kicks in when you have got full occlusion. Otherwise, you have to be careful you don't go to level 3 at the time that you have your occlusion. And the other trick is just rotate because the bevel is such that it gives you a less cross-sectional area to occlude. But if you rotate the handpiece by about 45 to 60 degrees, you'll actually get better occlusion, which happens much more quickly than if you use it in the conventional way of the trenching.
In fact, that's a very good question which she asked. The vacuum settings.
Yes.
people talk about higher vacuum settings for better control.
The divide and conquer and the stop and chop, and now we're coming to direct chops. And Dr. Ashu also has to leave for the same IC after this, so we'll also take his questions after this.
But can I ask one question before you start your presentation? Why is your direct chop daring?
This was a topic given, but chop is generally considered daring. I don't know, somehow, although I don't subscribe to the view, but many surgeons believe that whoever chops is a more daring surgeon, although I totally disagree with that viewpoint, although this is my preferred technique. Good evening everyone, and thank you Saurav for having me as a part of this course. So I have no financial interest in any of the products or techniques mentioned. So nucleus disassembly or nuclear fractus, essentially we've seen there's cracking, divide and conquer covered by Dr. Noshishroth, and chopping, which can be of two types, stop and chop, which is actually a mixed technique, and a direct chop, which is what I'll be covering today. It was first described by Nagahara in 1993, and since then many variations have evolved. And as a result, there have been too many names in the literature, which has caused significant confusion as regards nomenclature and the technique also. In fact, about 15-16 years ago, I remember many surgeons would be coming out with some modification of the technique, and they would give it a different name. So at that point I found it very confusing, but now let's see if we can just reduce it and get back to the basics. Chopping essentially is of two types. It is a horizontal chop or a vertical chop. Horizontal chop is the classical Nagahara chop, wherein the instrument tips, that is the phaco tip and the chopper, they move towards each other in a horizontal plane, like this. They come in a horizontal plane. Vertical chop has various variants and names also, like the phaco quick chop or phaco snap and split. But the difference from the horizontal chop is that the two instruments move towards each other in the vertical plane. So basically the phaco tip has been embedded in, the chopper comes from top like this and they move up. So the movement is vertical. So that's why it's easy to remember, it's called vertical chop because the movement is vertical, the plane of movement, and a horizontal chop, the plane of movement is horizontal. I'll cover this in a little greater detail and it will become clearer. So just to look at it, here we have a traditional the horizontal chop, where there is a chopper which is going right down to the periphery of the nucleus, and the phaco tip has been embedded here. In the side view, you will see that this is where the phaco tip, the chopper tip is entering. And in the phaco vertical chop, also known as the quick chop, the phaco tip enters closer towards the center. It does not go beyond the rhexis, and there in the side view, this is how it will appear. So let's see, what is the basis of all chopping techniques? They utilize manual instrument forces to divide the nucleus. Ultrasound power thereby is required to sculpt, which is required to sculpt is reduced, and this is possible because of the lamellar. The chopping is possible because of the lamellar orientation of the lens fibers, which provide natural fracture planes. So what are the advantages of phaco chop? Because of less energy used, because of we are doing a manual technique here, we are not sculpting, less ultrasound energy is used. There is less stress on the zonules, because if the zonules are weak and the phaco probe is moving forward, it will cause stress in the zonules. And when you are chopping, all forces are directed inwards and away from the zonules. The phaco tip always remains in the central 3 to 4 millimeter of the pupil, and therefore that is a safe zone. As we all know, is the safest zone to work in. And it is a relatively safer technique in complicated or difficult cases like small pupil phaco, zonular weakness or dehiscence, mature cataracts, hypermature Morgagnian cataract, and as we discussed earlier, there is no other technique which would possibly hold the nucleus in a Morgagnian cataract, and suboptimal capsulorhexis or hydrodissection. So let's look at the horizontal chop. There is a central debulking of the epinucleus. This is a constant feature. Whenever you do a chop, a central debulking is done of the epinucleus, and then a blunt chopper is advanced under the capsule to the distal equator of the nucleus, that is the end distal away from you, and phaco tip is embedded proximal to the center of the nucleus. In any chopping, you have to have a good purchase of the nucleus. The phaco tip should be at least around half the depth of the nucleus. Chopper is advanced towards the phaco tip and the chop is initiated. As the two tips come closer, this is how you're going, as the two tips come closer, there's a lateral movement. You give a lateral movement, so the vector force changes, a lateral movement which causes the separation. And the two halves are separated. Then once the two halves have been separated, the nucleus is rotated and each half is then further chopped into smaller pieces. In contrast, in the vertical chop, the first part remains the same, the central debulking of the epinucleus. phaco tip is embedded at the center or distal to the center of the nucleus. So here basically you're going deeper because I'll just tell you why. And the sharp chopper is buried downwards into the nucleus. It's coming from top, the tip is embedded there, and like a spike, just anterior to the phaco tip. Because it's going to, here you have the forces acting toward, you're compressing in horizontal chop, you're compressing the nucleus within the two instruments like a sandwich and you're cutting through. Here you're not doing that, you're just pushing it in and lifting the embedded phaco tip a little and trying to split it. So therefore there has to be a deeper penetration of the phaco tip, and it has to go right to the center of the nucleus or even a little below that, a little distal to that. And then the chopper comes from top. The chopper is advanced towards the phaco tip and the chop is initiated, and again here also, as the two tips are coming together, a lateral movement is initiated and the two halves are separated, and again the individual halves are then further chopped into smaller pieces. So if one wants to convert to phaco chop, what do we do? Because phaco chop is a little more technically demanding. So one should graduate from divide and conquer and or stop and chop, whatever they're doing. They should get familiar with chopping. How do you do that? Get familiar with choppers and chopping, the various choppers, and that's again a very confusing thing. We won't go into that here. And also the concept of chopping. So if you're doing divide and conquer, the 4 quadrants that you have, one would generally, if you have a good phaco machine, you generally emulsify the 4 quadrants. But instead of doing that, you try and hold each quadrant and try and chop it. So basically you have to learn to use the left hand to chop. And then if you are doing a stop and chop again, the second half you should again try and chop it also. So people believe that horizontal chop is a little easier and should be started with, followed by vertical chop. Although I feel that they're equally, in fact, I prefer the vertical chop because I personally feel that the horizontal chop is a little riskier when you're going towards the periphery under the capsule. You're going under the capsule towards the periphery of the nucleus. It can pose certain challenges. So let's compare horizontal and vertical chop. They both work on different principles but offer the same advantage. That is less ultrasound energy, less stress on zonules, and the phaco tip remains the center in the safe zone. In terms of degree of difficulty, both have a steeper learning curve than stop and chop or divide and conquer, but learning one will eventually help in learning the other. They both have some risks, especially during the learning phase. In the horizontal chop, the risk is of the chopper damaging the anterior capsule or the zone, because you're going under the capsule, and if you don't judge properly, if the view is not very clear, you may go over the capsule, damage the capsule, go right up to the zonules and damage the zonules. In vertical chop, there's especially when you're beginning, although we don't really face it once you have some experience, the risk of posterior capsule rupture is there if very excessive pressure is applied downwards in the downward movement by the chopper. So the indications for horizontal chopping, if you compare both horizontal and vertical chopping, softer and smaller nuclei, extremely deep anterior chamber like high myopes, post-vitrectomy eyes, or even deep-seated eyes, because in those cases the chopper, if you're doing a vertical chop, you have to go deep. So as it is that eye is deep, or the lens is deeper in the plane, it's difficult. So therefore the horizontal chop may be a little more easier in such situations. And in small pupil, the vertical chop also works very well. In vertical chopping, the indications are difficulty visualizing the capsulix's edge, like in a corneal haze, a scar, or anterior cortical spokes, brunescent nuclei and leathery nuclei, where there is little or no epinucleus, because if you don't have epinucleus and you're trying to do a horizontal chop by going to the periphery of the nucleus under the capsule, you might damage the capsule, and in small pupils. Unfortunately, my video film that I had created is not working. So I have the raw footage which I would like to show you if we have time. I think we have 3-4 minutes. So it'll be a bit of an effort, and I know it's going to be painful, but just bear with me. I'll try to demonstrate what I've been talking about. So you see here that central debulking is done.
What is the tip you're using?
So these are videos that I've collected which are very old. This is a Protege, I think. No, this is a Millennium. It's a 30 degree tip. Yeah, it's a 30 degree tip, which would be a preferred tip in these cases.
And what is the chopper you're using? What is the length of the chopper?
So this is an Agarwal chopper, the Epsilon Agarwal chopper.
So what is the?
It's about a little over 1 millimeter, I think.
Sharp chopper.
It's a sharp chopper, but it's not very long. In fact, off late, these are old videos. I wanted actually to show how my learning curve, and you will see certain mistakes that I made. That was the idea of collecting these videos. But now I use a sharper chopper, which is like a spike. It's about 1.5 millimeter, and it chops in much. You'll see a bit of a struggle in some of the videos here, and it chops much better. These are, I think, videos of 2002 or 2003.
So the standard now is 1.5.
1.5 is the standard, yeah. This one is a little shorter than that, the Epsilon Agarwal chopper.
And an ideal tip would be a higher degree tip or a lesser degree tip for a phaco chopper.
Ideally, we get this is a 90-degree tip. I would prefer a
15 degree, 30 degree.
No, the phaco tip or the chopper tip? Angle. Okay, the phaco tip. If you're doing a direct chop, you want more purchase, you want more hold, you don't want sculpting there. So a higher degree would be better.
So if you have a...
But 30 is a good balance actually.
So if you have a 15 degree tip, it would be even better.
15? No.
From
15 degree would be better. It would be better, but
the disadvantage would be
less sculpting, less cutting power. So therefore 30 is a good balance between all these.
So in fact, at one time when they were getting to more flatter angles, they even came up to 0 degree. So
0 degree, but that didn't work. That didn't work too well.
It didn't work too well, so they got back again, and the best standard was.
So this is another video showing the similar situation. Here again, the central debulking is done. It's always better to do this because it'll give you a fair idea of what you're dealing with.
Is it important to do the central debulking?
I think it's important even in stop and chop.
What advantage is it giving?
It gives you less. It clears up this working area, and you see the chop has been initiated.
You're removing that soft.
The chop has just
soft cuttings.
No. Central debulking.
Debulking.
Central debulking. That's with the area which will go anywhere when you're chopping or you're doing anything with the phaco. So this was the vertical. I have one of the horizontal ones also, but vertical is my preferred. Horizontal you have to go to the right under the capsule. You have to go to the periphery. And vertical, and this is actually what you're seeing here. The tip is also tip is fine, but the phaco chopper is not the ideal chopper. It is reasonably sharp, but it's shorter in length. A little longer chopper would work even better.
Is anybody using a vertical chop now in the audience or anybody? Because I think everybody has more or less shifted to horizontal chops.
No. I don't agree with that.
Sorry, vertical chops.
People have gone to vertical.
Shifted to vertical chops. Is anybody using a horizontal chop? Horizontal chop?
Yeah, actually, I would agree. Sometimes you need to use both, or in fact, in one of the videos you might see a combination of both. So this is another video. This is just to give you some idea and some mistakes that I made. Now you'll see probably in this video where the depth is not adequate. The phaco tip is not penetrating enough.